Tokyolive Endoscopy 1.
It's a great honor and a privilege for me to introduce Professor Guido Costamagna for his lecture at Tokyolive 2021, following the generous invitation of Professor Haru Inoue, who should in fact introduce his friend and eminent colleague. Professor Costamagna is preceded by his international reputation as an expert in pancreatic and biliary diseases. He's a full professor of surgery at the Università Cattolica del Sacro Cuore in Rome, Italy. And he's also president and director of multiple foundations and scientific societies, well known as surgeon and endoscopist, I think sharing some values with Professor Inoue, being both expert in both fields. And I have also to underline that he trained partly in Belgium. And you know, Belgium is going to win the Euro Football Championship, of course, where he was trained by Professor Michel Kremer, and I think they were good friends. And we share a lot of the training Professor Kremer gave us in the past. His internationally recognized expertise is reflected by his participation in multiple European, American, Japanese scientific societies and live meetings, and also the publication of more than 500 publications with an age index of 76, which is impressive, of course. His main areas of interest are therapeutic endoscopy, in particular biliopancreatic endoscopy, including minimally invasive surgery. He has developed multiple devices, training tools, such as the Boskowski-Costamagna trainer for ERCP, used by many fellows in Europe, and proposed endoscopic treatment algorithms that are bearing his name now in my units and in many other units. He's an excellent lecturer, and I have no doubt that his lecture entitled Endoscopic Treatment Options for Chronic Pancreatitis When is Surgery Indicated will be a milestone during this Tokyolive. Guido, it's an honor for me to introduce you. I'm very eager to hear your lecture.
Thank you very much, Pierre, for your very, very kind, extremely kind introduction. Yes, I've been trained in Belgium by this guy who's here behind me and controlling what I will say in the next few minutes. And as you know, I'm linked to Belgium very strictly because also my spouse is Belgian. Therefore, and it's my second home. So thank you again also to Haru, my great friend Haru Inoue, for inviting me to this very important meeting, Tokyolive 2021. I will try now to share my screen. In the next minutes, I will address this problem, the endoscopic treatment options for chronic pancreatitis, but also the indications for surgery in this disease. These are my disclosures. So chronic pancreatitis is a disease that has a very variable spectrum, a disease that we cannot cure completely, but we can address the symptoms. And the main symptom is pain. Pain may be obstructive or inflammatory, and in obstructive pain, endoscopy, both endoscopy and surgery may be useful, while in inflammatory origin of pain, surgery is probably much more effective, medication less. In complications, pseudocyst may be treated both by endoscopy and surgery, as well as the bile duct stricture that can develop during the natural course of chronic pancreatitis. Duodenal stricture is mainly treated by surgery, but we will see that we have also endoscopic options now. And then medications are useful, of course, if there is a complication involving the veins around the pancreas. The origin of pain in chronic pancreatitis is due to different reasons. One is the parenchymal ischemia due to the compression of the parenchyma due to the distension of the pancreatic ducts. Pseudocyst per se may be also a cause of pain, of acute or chronic pain, and then nerves entrapment around the pancreas by the inflammatory process may be also a cause of pain. Endoscopy may address mainly the obstructive pain due to strictures, stones that induce a main pancreatic duct dilation. In this very important paper that is now more than 20 years old, a man in Switzerland analyzing a cohort of patients was able to define two main patterns of pain. The type A, which is intermittent pain with long or short pain-free intervals, but also years of pain-free intervals, which is the most frequent kind of pain in chronic pancreatitis. Probably more than 80% of the patients suffer from this kind of pain. Then type B, which is a constant pain, persistent pain, that can be exacerbated for periods. This is a minority of patients. Usually, the intermittent pain is more frequent in the early phases of chronic pancreatitis, while the persistent pain occurs when we have complications like pseudocyst or important dilation of the pancreatic duct due to stones or strictures. Of course, the aim of any treatment is to decrease and to abolish the pain. But as you can see here from the same paper of Aman, both cohort of surgical patients and non-surgical patients had more or less the same follow-up in the years concerning the pain. This is why, because surgery may be done only once, and this is the main difference for a chronic disease between surgery and endoscopy. Endoscopy can be repeated many times, every time it is needed. It's important to define the morphology of chronic pancreatitis. And we usually do it with the classification proposed by Kremer in 1976 that was based on ERCP. And you see it here on the left. But now we have magnetic resonance cholangiopancreatography, which show very well the features of the pancreatic duct before any kind of intervention and before opacification. So the class number 5 of the original Kremer classification is no more there because this was due to a complete blockage of the injection due to a stone or a stricture, which is now is clearly visible in with magnetic resonance. So type 4 and type 5 has become now with MR type 4. Why morphology is important? Because endoscopy may act on the hydraulic, let's say, part of the disease. May act on the blockage of the pancreatic ducts. So to indicate endotherapy, we have to have both symptoms. Of course, it's if there are no symptoms, there is no indication to treat the patient, and morphology. And of course, if the morphology is severe and the symptoms are severe, these are the best candidates for endoscopic treatment. There are two main features in the chronic pancreatitis. Dominant pancreatic strictures, dominant because they occur on the main pancreatic duct, the Wirsum duct or the Santorini duct in case of pancreas divisum, and pancreatic stones, or a combination of these two features. Pancreatic stones are, since many years now, addressed with extracorporeal shockwave lithotripsy. Why? Because they are usually impacted in the duct. Apart from a rare case of idiopathic pancreatitis or pancreatitis occurring in young people, most of these stones are firmly impacted into the fibrosis of the stricture of the main pancreatic duct. And therefore, it is almost impossible to extract them without a previous lithotripsy. And this is the meta-analysis published 15 years ago already, showing the effect size clearance on the duct of the SWL, which is quite good, as you can see in the table. Most series are small, apart this one that comes from the very well-known Asian Institute of Gastroenterology in Hyderabad, a group of Nagi Reddy, that published a few years ago a study of more than 5,000 patients. And the complete clearance was achieved in more than 70% of the patients, 3/4 of the cases, pain relief in 82%. Another more recent meta-analysis and systematic review of the studies published after 2000 was published recently in 2020. And again, this shows a very high stone fragmentation rate, 86%, and a pain-free proportion of patients of 64%. We can conclude that then ESWL is quite effective in this situation, and it is used very often. This is a series that we performed here in my hospital until 2014 on 350 patients with chronic pancreatitis and that underwent ESWL. We had at that time a follow-up of 172 patients, and these are our results. You see almost 60% of complete pain relief and 30%, another third of partial pain relief, while 12% of the patients did not had any improvement also after endoscopic treatment. Now, can ESWL alone be a treatment for chronic pancreatitis? We conducted this randomized trial prospective a few years ago with a group of Jacques Devier in Brussels, which was published in GAT in 2007, comparing ESWL plus ERCP to the ESWL alone in a subgroup of patients without dominant strictures. And these are the results. The pain relapse at 2 years are very similar. The number of pain episodes per year were definitely improved by both treatment. However, the hospital stay was much shorter for ESWL, and the cost also was only 1/3 of the cost of the ESWL plus endotherapy. This was at a follow-up of 4 years. What does it mean? It means that probably in a subgroup of patients, we can avoid ERCP and we can start the treatment only with ESWL. And if effective, we can wait for recurrence of pain to decide if these patients need or not intervention through endoscopy. There are no, at the moment, prospective randomized trial on ESWL, and we hope to have very soon the result of this one, the short trial that was proposed in last year only as a protocol and is now ongoing, but we don't have still the results. Another way of taking care of stones is to approach the stones endoscopically with pancreatoscopy and to fragment them with laser or electrohydraulic lithotripsy under endoscopic control. This is an example of a spyglass introduced into the main pancreatic duct. You see the whitish color of the stones very well, and the shock wave that are delivered directly on the stones that are quite effective. The problem is that the stone should be floating into the pancreatic duct, and as I told you before, this occurrence is not very frequent because most of the stones of chronic pancreatitis are embedded in fibrosis and therefore difficult to reach with the pancreatoscopy. You see here the fragments extracted with the Dormia basket after lithotripsy at the direct view. A short series of patients was recently reported by Gerges from Düsseldorf. However, the effect was quite good of this technique. Now, the other problem is strictures of the duct, and stricture are usually addressed with stenting. Stent mostly used are plastic stent, and you see here the results of several papers published in the last years, showing the results of placing one plastic stent, large bore, usually 8.5 or 10 French, for 6 months. The clinical success is only 30 to 50%. But if you leave the stent in place for 2 years, changing it after 1 year, the clinical success reaches 60 to 70% at the follow-up of 5 years. Some years ago, we proposed the same strategy that we adopted for the benign stricture, postoperative stricture of the bile duct by placing multiple stents for 6-12 months also in the pancreatic duct. And we were able to improve in these unrelenting strictures, not responding to one stent, to improve our result to 74% at 9.5 years of follow-up in a series of 48 patients. So I think that in a subgroup of patients, this could be interesting, even if in another paper coming from Brussels, that was a retrospective comparative study of one stent, 1 or 2 stents, or 2 stents, there was actually no difference in terms of results between these policies. But the group of patients was a little different from what from the one that we treated with multiple plastic stents. Another option is to use metal stents. Unfortunately, this is the benign disease. We must be able to remove the stents, and therefore we have to use fully covered stents that migrate quite easily and may impact in the duct and create other strictures. This is the paper that we published 3 years ago in a patient with failed stricture resolution with single plastic stent. The stricture resolved in 93% of the patient, and 90% were asymptomatic. However, there was a high incidence of migration and also a high incidence of induced main pancreatic duct stricture that required plastic stent afterwards. You see, 1/4 of the patients developed this kind of complication. So this stent is probably not yet the ideal one. Some other experience in the literature, these are data coming from the US. A small experience, 33 patients at 5 centers, but with a clinical success very high, more than 90%. And recently, this Korean group published another kind of stent, which is a suspended stent inside that can be left inside the duct and removed through a thread that is coming out from the sphincterotomy. The successful endoscopic removal was very high, the distal migration very low, and at a median of 3 years follow-up, most of the patients were asymptomatic. So this is something that we have to try also when the stricture is not in the head, but in the body of the pancreas. What about children? Children may be treated endoscopically. This is our series of 38 children with the age of 13 years and 7 years follow-up. The pain severity was significantly improved after treatment, and also the pancreatitis episodes were much less after treatment. Of course, again, these patients sometimes come back with recurrent pain and have to undergo multiple procedures. What about complications? Pseudocysts today are mainly treated by endoscopy, and I will not discuss this point. Common bile duct stricture very often are still treated by surgery by creating a hepatico-jejunal or choledochondrial anastomosis. It's a definitive treatment, but if the stricture occurs, retreatment is challenging. Sometimes requires the percutaneous approach. The anatomy is difficult to reach, and therefore fully covered SEMS beta stents have also been tried in the setting of chronic pancreatitis, and a recent multi-center trial involving 180 patients achieved 80% stricture resolution and a stent-free success of 77% at 5 years. This was the original publication in gastrointestinal endoscopy last year. Duodenal stricture is usually treated by surgery. However, we must keep in mind that today, in patients that are at high risk of surgery, we have also another option, which is the creation of gastrojejunal anastomosis by using luminaprovsic stents. So finally, which is the role of surgery? Surgical options for pain are classified into 3 categories: decompression, which focus on ductal hypertension; resection, when there is an inflammatory mass or a suspicion of pancreatic cancer; or combined procedure. And of course, as endoscopy, surgery has to be tailored to the needs of patients and should be organ sparing in centers with expertise in pancreatic surgery. There are few studies comparing surgery to endoscopy, and in this Cochrane database systematic review, only these 2 trials were compared. However, both of them have some bias. Data from the Czech Republic did not have access to lithotripsy, and the study of Cain has also a lot of difficult point to interpret. But however, these 2 studies show a better success with surgery in terms of pain relief. Also, another recent randomized clinical trial, very well done by the Dutch pancreatitis study group, randomized 88 patients into early surgery or endoscopy first approach, showing better results with surgery. However, these patients were under opioids, which is already something that occurs usually late in the natural history of the disease. Looking at the guidelines, these international societies, even if surgery seems to be better than endoscopy, finally indicate as a first approach endoscopy, and only not the good candidates for endoscopy or failed endoscopy, they proposed the surgery. This was the opinion also of the Japanese Society of Gastroenterology. In all these situations, pain, complications, first, of course, medical conservative treatment, but then always a trial of endoscopic treatment, always. And then only as a third approach, surgical treatment. And also the guidelines of the European Society of Gastrointestinal Endoscopy, even if the recommendation is weak because the evidence is low quality, indicate that ESWL and endoscopic therapy may be the first approach in the majority of these patients, and that the surgery should be discussed only after recurrent pain or failed endoscopic approach. So to conclude, I think that chronic pancreatitis, being a spectrum disease, has a need to be tailored around every single patient, that should be informed, that should be reassured on the natural history of the disease. And of course, we must be ready to answer to answer to all the questions of our patients in terms mainly of risk of recurrent pain. And I finally think that being endoscopy repeatable, it makes sense to try to apply repeatable endoscopic treatment for chronic disease instead of a very aggressive surgical approach. Thank you very much for your attention.
Thank you, Guido, for this very clear lecture on the different endoscopic treatments that we can offer to our patients with this chronic disease, which is a quite debilitating disease that's changed their life for their entire life. You mentioned different ways for the treatment of pancreatic stones, mainly ESWL and also endoluminal lithotripsy with pancreatoscopy and EHL or laser lithotripsy. How would you select the patients for these two options?
I think that the preoperative assessment with MR is very important, because if MR and CT show a dominant stricture and the stone seems to be impacted in the stricture, which is the case very often in patients that have chronic pancreatitis also due to some alcoholic abuse, ESWL is the first choice, of course, because the stone would be very difficult to reach under pancreatoscopy. In cases of reachable stones floating or even bypassed with by a stent for some times before, in order to enlarge the stricture, eventual stricture, or to make the access easier, I think that the endoscopically guided lithotripsy may be very, very nice options, because it's very quick and very effective.
Do you mean that endoscopist or a pancreatic center should give access to the patient both for ESWL and ERCP? Because we still see a lot of centers in Europe where they have sometimes several attempts with ERCP to drain a pancreatic duct that's obstructed with large stones. And then they refer only after second or third attempt for ESWL. So do you confirm the message that it's important to perform ESWL first? Or which are the patients where you could have a try to attempt drainage without ESWL?
That's very important. We always, if we have the information by CT and MR that there is an obstructive stone at the head of the pancreas, the first step is always ESWL. And then usually in our setting, the following day, we proceed when we have the fragmentation of the stones. Sometimes you need more than one session of the ESWL in the following days. And when we are satisfied with fragmentation, then we proceed to ERCP.
Okay.
Try
also,
to which is effective. Doesn't make any sense.
you showed the data from Hyderabad, and I went there to see how they were doing their lithotripsy, and it was very informative for me many years ago, because they did this under general anesthesia with full power of the lithotripsy. And I noticed that in Europe, some centers are still doing lithotripsy without anesthesia, and then with a much lower energy setting. And therefore, then the stones don't break, and sometimes they need several sessions to achieve this. So could you really explain how you should perform ESWL in these patients with large stones?
Ideally, you should be able to do it under general anesthesia, and then immediately after ERCP. For instance, in Jacques de Vier department, the ESWL room is just close to the ERCP room. This is an ideal setting. In my hospital, this is not possible because the ESWL is mainly used by urologists, which are located on another floor. So we do ESWL under general anesthesia or deep sedation with propofol, and then the following day we proceed to ERCP. But it's a question of logistics. Of course, if you are able to have the same general anesthesia for both, it's ideal. But I agree with you, to be effective, there are two very important points. The first one is that lithotripsy for pancreatic stone should be done by a gastroenterologist or by endoscopist or by a technician who is fully involved, or a nurse fully involved in endoscopy, and not by the urologist, because it's completely different. You must be focused and want to crash the stone and not just use time. This is a very important point. And the second point is that the patient should not suffer. And if you want to use high power, then the patient should be very well sedated or even in general anesthesia.
In your lecture, you didn't mention EUS at all for chronic pancreatitis, and you know I have an interest into EUS. So what should be the EUS part in the treatment? Because we have patients with altered anatomy, or patients with complete strictures, or patients with previous acute pancreatitis and disconnected pancreas. So,
matter of time, I did not approach the problem of pseudocyst and cyst. Of course, these are, it's scientifically evident that there is a step-up approach with, first of all, an endoscopic ultrasound guided drainage through the duodenum or through the stomach. This for pseudocyst and cyst, retention cyst. For failed passage of a stricture, it is possible to approach the duct above the stricture by pancreatostomy, and then doing a combined procedure by passing the guide wire through the stricture and the papilla, and then with a ERCP find the way, or even place a stent in the only under endoscopic ultrasound guided puncture. And the same is true for disconnected duct, of course, when you want to create a permanent fistula with the stomach. And it has been shown that in this case, it's very important to leave inside forever the plastic stent. Otherwise, you have recurrent collections in the fractured duct, where the duct is interrupted.
Yes. Also, in failed access to in the pancreas to the major papilla, it's very important, I think, to have a full imaging before CT and MRI to check if there is no better access to the minor papilla. So, do you have also the impression that sometimes the treatment of these patients is easier through the minor papilla because you have a straight access to get to the main pancreatic duct?
Absolutely. In case where you have a difficult anatomy, like an alpha anatomy or a partially divisum or H anatomy. Sometimes it's much easier to go through the minor papilla. We have probably the need to access the minor papilla in at least in 20% of the patients. Which
yeah,
is
I have
much
the same impression in my center, yes. And maybe last question about surgery. In many multidisciplinary discussions with surgeons and biologists and other people interested into pancreatology, total pancreatectomy with autotransplantation, islet autotransplantation, TPAT, is gaining some popularity or interest in Europe and United States and maybe in Japan. What is your, especially in children, because you show data in children, but we have children where endoscopic treatment is not so successful, many stent exchanges, quick recurrence of stones, although they don't smoke and there is no toxic addition. And those children are really painful, and we hesitate to put them under opiates, of course. So we often have the discussion on TPATs. And do you think this has also an interest in adults?
Of course, it has an interest, but I think it's a real the last solution when we have tried everything, because it's very aggressive and risky also surgery. So I'm not sure it is yet the opportunity for the majority or for many patients. It's just a very, very, very small minority of patients. In my experience, I have never experienced the necessity of total pancreatectomy.
Okay. And for the future, are you waiting new devices or new endoscopic techniques for the pancreas, for pancreatic endoscopy?
New devices, of course, we are also always waiting for new devices. Where we are still fighting a lot is, but this of course, complications of pancreatitis is necrosectomy, for instance. I don't think we still we have the right device to be effective and quick and effective enough.
Yes.
So there's a field where we can improve a lot.
Yeah, you published on new devices in necrosectomy, and there are new devices coming on the market. But of course, those devices, they're also always at risk of inducing more bleeding, and that's one of the things we really fear when we use more aggressive devices. So I think these were the questions that that I could raise after your beautiful lecture. I don't know if you have other comments to do or to Haru.
No, I would like to thank you again for inviting me, and I miss Japan.
Yes.